Is it visible?
Yes, sir.
Okay. So you don't have to classify this as a pulmonary arterial hypertension because hypertension can happen if you remember the basics of pulmonary circulation. The so-called pulmonary artery arises from the right ventricle.
Mm.
And even though it is called an artery, it is the deoxygenated venous blood which is pumped into the pulmonary artery. Because it is coming out from the ventricle, it is called an artery, but in reality, it carries the deoxygenated blood. It goes to the ramification, divides into right and left pulmonary artery, goes to the two lungs, and then gets divided into various branches to ultimately become the pulmonary capillary circulation close to the alveoli and then rejoin to form the so-called pulmonary vein, which again is four numbers. Artery you have only two, whereas pulmonary vein you have two on the right side and two on the left side. So four pulmonary veins come and join the left side of the atrium to deliver oxygenated blood into the left side. So the pulmonary hypertension can happen from the starting point at the pulmonary artery. It can happen at the capillary junction. It can happen post capillary to the on the venous side, which even though you call it as pulmonary vein, it carries the oxygenated blood. So that particular anatomical disposition, if you understand most of the way how to classify that will be understood. So as you rightly said, some books say the mean pulmonary artery pressure greater than 20 millimeters is considered as a pulmonary hypertension. Some books say 25 also is accepted. But definitely it is diagnosed as correctly by right heart catheterization and not by other features like echocardiogram or transesophageal or transthoracic. And it's caused by the now, what exactly happens is the vasculature itself becomes changed in this particular pathology. So, the vascular proliferation, arteriolar vasoconstriction, left heart disease, which elevates the pulmonary venous pressure, or inside the thrombosis. These are some of the causes for the pulmonary pressure to go up. Normally, it is a low pressure circulation, as you all know. So the pressure is not that much as you have in the systemic vessels. So even a small elevation causes a good strain on the right ventricle to empty its volume into the circulation. And any surgery can exacerbate this pulmonary hypertension, leading to complications like arrhythmia, congestive heart failure, myocardial ischemia, respiratory failure, hemodynamic all this. Now coming to the classification and definitions of pulmonary hypertension, there are 5 groups have been described. This is the this classification is according to the World Health Organization into 5 groups: Group 1, 2, 3, 4, 5. And Group 1 is actually the pulmonary arterial hypertension. That is when the vessel comes out of the right ventricle, the pulmonary artery, it can become a stiff vessel which causes an increase in the pressure. And this was originally called as primary pulmonary hypertension, which is a disease of the pulmonary artery which is coming out of the right ventricle. And it also is called idiopathic pulmonary hypertension. It's usually associated with connective tissue disorder. The second group is associated with pulmonary capillary wedge pressure. That is at the level of the capillaries, which is usually due to left-sided heart disease, common with mitral stenosis cases which we come across. We are always worried about the increase in the pulmonary pressures. And then third group is the COPD and other cases where the alveolar distortion or the lung pathology causes an alteration in the vasculature. This sort of vascular proliferation, arterial vasoconstriction, all these things resulting secondary to lung disease. The fourth group is thromboembolic phenomena, which is occurring or blocking the circulation, which will automatically elevate the pressure by causing a resistance to the flow. And the last thing is systemic disorders, multiple mechanisms, including sarcoidosis and nephrological conditions. So, You have to imagine the whole pulmonary vasculature, starting from the pulmonary artery, the capillary system, the venous system. Then the group 1 is the arterial, group 2 is the capillary or left-sided disease, 3 is lung disease, which is unconnected to the circulation, secondary to lung pathology. Fourth is the thromboembolic phenomena causing a mechanical obstruction, and finally systemic disorders causing this problem. So these are the 5 categories of pulmonary hypertension. And what happens to the pressure changes in the mean pressure will be always more than 20 in all these cases. But the pulmonary capillary wedge pressure will be changing. It will be more when there is a isolated pulmonary hypertension, and the other conditions produce decrease in the pulmonary capillary wedge pressure. So that is how you differentiate between the right side and left side pathology. And this is another picture to show which group belongs to it. That is the arterial side. This is called the pre-capillary pulmonary hypertension mean. This is the pulmonary arterial system coming out of the right ventricle. Their mean pressure is more than 20, but pulmonary capillary wedge pressure is less than 15, and pulmonary vascular resistance is more than 3 Wood units. So these are the 3 things which are measured, and the group which I showed earlier belongs to 1, 3, 4, and 5. So out of the 5 categories, except the 2, you will have these changes happening in these 4 groups. And isolated pulmonary post capillary will be mainly in the second group, that is the left-sided valvular disease or left heart failure function. You will have this increase in pulmonary capillary wedge pressure also will be more, and other things will be similar to the normal hypertension. And the combined things will be seen in both these 2 and 5 group, where there will be sort of increase as well as the wood pressure also will be increased. All these things will happen in the group 2 and group 5. Now this picture is a diagrammatic representation of the lung is here. The class 1 is the pulmonary artery. As I told you, it is carrying the deoxygenated or venous blood. So the class 1 is the pressure developed due to the fault in the pulmonary artery, which is emanating out of the right ventricle. Then the second group is the left heart disease, where the left ventricle is not functioning, so it produces pulmonary venous pressure, which is also considered as a pulmonary hypertension. So first category is pulmonary arterial pressure, second category is pulmonary venous pressure due to left heart disease, third category is to pathologies in the lung producing pulmonary hypertension, fourth category is the mechanical obstruction due to thrombus, and fifth category is mainly because of the hematologic or systemic or metabolic diseases unconnected to any of these things, but producing changes in these vessels, both on the arterial side and venous side. So this picture, if you remember, you will be able to classify this into the 5 groups that you want to take. So based on that, you must be able to assess the risk in these patients. And the risk in patients can be classified into low risk, intermediate risk, and high risk patients. And what are all the things which decide whether the patient is low risk? There is no right heart failure, no progression of symptoms, no syncope, no chest pain, no arrhythmia, but the pressure is slightly above 20, then you consider that person as a low risk patient. And world functional status is grade 1 or 2, say grade 1 or 2, or a WHO functional 2. Whereas patients who have still not having right heart failure, but syncope, chest pain, and arrhythmias are present occasionally, and there is some restriction of activity, then it is called intermediate. Whereas in the high risk group, patient is in fact right heart failure, he will have very rapid progression of symptoms, and he is feeling or experiencing syncope, chest pain, arrhythmias, and his activity, day-to-day activity is Sorry, very much limited, then it is a high risk patient. And if you do the imaging and hemodynamic studies, here the various factors, findings are given, and in the extremely high cases, right atrial area is more than 25 centimeters, pericardial effusion may be present, the ROT is more than 14. So this slide is very important to remember what all the various factors which are parameters which get altered to assess the risk. So, and if you do the biomarkers test, BNP and ST-proBNP, this will be well below very high levels in low risk patients, and it is extremely high in high risk patients. So, by doing this, you can assess the degree of right ventricular failure in these patients and make the risk classification. So, high risk patients, why you want to do this risk stratification? Because low risk patients will not give you any trouble. You can manage them in the normal way by preventing any further rise in the blood pressure. Whereas high risk patients are always in the imminent danger of acute right ventricular failure on the table, which will go on to affect the left side function also. And these factors will alter the pulmonary vascular resistance. So intraoperatively, we have to take care of that. Factors which raise the PVR are hypoxia, hypercapnia, acidosis, systemic release, serotonin release, and alpha activated fibers. And factors which lower the PVR are hyperoxia, hypocapnia, alkalosis, nitric oxide release, prostacyclin, sympathetic and parasympathetic cholinergic fibers. Now, what are all the pros and cons of anesthetic techniques which you use? So, if you use regional anesthesia, it is excellent opioid sparing technique, and there is no cardiac respiratory depression provided the sedation is mild or avoided. But the disadvantage that is regional anesthesia is like a plexus block or a nerve block. It is not spinal or epidural, it is isolated limb block. This is quite good for surgeries on the upper or lower limb. But it is not suitable for majority of the time. You can do certain surgeries, but it may not be suitable for all that. And you must know whether the patient is able to lie flat for the complete duration of the surgery. If it is a prolonged surgery, even if you put a catheter and continue the anesthesia, patient may find it difficult to lie conscious for a duration of surgery and develop significant respiratory distress. The central neuraxial blockade, like spinal or epidural, they are also quite opioid sparing, because opioid sparing is important to prevent the aggravation of the pulmonary hypertension. And but high blocks will cause basalt jaundice reflex and cause a direct sympathetic blockade, and not suitable for many types of surgery. General anesthesia, you have to advantage, you have a secure airway control, ventilation can be adjusted according to the need, reduce risk of intrathoracic pressure like coughing and other things, and you can titrate anesthetic agents and analgesia. But the disadvantage is anesthetic agents have a depressant effect on the cardiovascular and respiratory system, so you need to monitor them and take care of them properly. Now, perioperative events, how they can affect the parameters of patients in pulmonary hypertension are pre-medication. Three things you have to take care of. As you rightly said, heart rate, right ventricular contractility, and pulmonary vasculature. So, whether the right side heart or the left side heart, these are the three parameters which are going to decide the ejection fraction or stroke volume on the right heart or the left heart. So, heart rate, RV contractility, pulmonary vascular resistance are the three things which will be altered by your pre-medication, anesthetic induction, if you think of central neuraxial blockade, airway management, or the intraoperative pain, or the surgical procedures like lower lip and K, hypoperitoneum and cesarean section. So these are the things which will affect the various things which you have to take care of and try to manage that. Now coming to the patients with that history and physical findings, you have to do a thorough examination and find out whether they have been suffering from angina, stroke, or syncopal episode. Physical examination find for just mainly for right ventricular dysfunction like distended neck vein, tricuspid leak, you can murmur, you can hear a three gallop, and maybe hepatomegaly, abdominal ascites, and peripheral edema. So these things indicate a severe degree and decompensated right ventricular function. And investigation-wise, we have to do hemoglobin, hematocrit, metabolic panel, liver function, chest radiograph, ECG. Intraoperative monitoring, apart from the routine monitoring, you have to go for invasive hemodynamic monitoring based on the risk stratification that you have run already. Coming to the intraoperative management, for anesthetic induction, you can use high dose opioids or propofol with a vasopressor to prevent hypotension caused by propofol. Or even though ketamine is supposed to increase the PVR minimally, considered as a positive sympathetic response, increases right ventricular performance. At the same time, maintains SVR because if SVR falls, the PVR, the pulmonary pressure will be high and it will cause admixture. And low dose spinal or combined spinal epidural techniques are much more safer, has less effect on SVR. So maintenance of SVR is very important in all patients with pulmonary hypertension. And for ventilation, you must use a low tidal volume with a low peak for to favor gas exchange and minimize the admixture. Sometimes there may be a sudden increase in pulmonary hypertension causing what is called pulmonary hypertension crisis, and this can be precipitated by induction of anesthesia where the SVR falls. The PVR becomes very high and the pulmonary pressure dominates. And the laryngoscopy can use that hypoxemia, positive pressure ventilation, extubation, perioperative explanation, micropulmonary embolism, arrhythmias, all these post-operative fluid checks, all these can result in a sudden acute rise in pulmonary pressure. Then treat hypotension aggressively to prevent right ventricular ischemia, but at the same time maintain the pulmonary vasodilator. Reduce post-operative PVR using inhaled or intravenous pulmonary vasodilator. Inhaled nitric oxide is fast acting. This will be useful to dilate the vessels and reduce the pressure. Nebulized agents like prostacyclin, military non-intravenous agents like prostacyclin, sildenafil. We have to mention about sildenafil phosphatase 5 inhibitor, which is a very useful drug, but that is given by oral route. Improve RV function by optimizing preload, and adequate preload may carefully be monitored by fluid challenges or diuresis. Suitable inotropes include dobutamine, dopamine, and adrenaline. Drugs which can be used to improve the ventricular contractility. Then we must reduce the afterload of PVR. Just like when you want to improve the left ventricular ejection, you have to reduce the SVR. Like that, to improve the right ventricular ejection, you have to reduce the PVR. And so PVR reduction can be achieved by the above methods, and the use of ECMO to support RV sometimes as a breathing therapy. And the recent coronavirus infection, many patients develop macro pulmonary thrombosis. So that was the fourth category we saw, presence of thrombus in the pulmonary vasculature, which is one of the causes of pulmonary hypertension. So this leads to right ventricular dysfunction, and some patients have the sequelae of this infection resulting in residual impairment of the lung and develop pulmonary hypertension, which remains to prolong for them. So these are all the points that we added. I hope that is giving a clear picture of the hypertension, how to classify, how to assess the risk, and how to manage a patient with